I'm particularly happy that Professor Jeffery agreed to give the first talk, because back in a year ago, the Wellcome Crest did a call out for the Global Health Research Centres. If you looked across the university, where we were perhaps a little different to others, was our real strength in sociology and anthropology and ethics of work across Asia in particular. Professor Jeffery is the Professor of Sociology of South Asia. He's also the Dean International, in brackets, of India, and also the director of the Edinburgh India Institute. And I'm talking to us today about a series of work he's been doing for the last 30 years, or 40 years perhaps, in India. So thank you very much.
Thank you, Mike, for that introduction. And I'm sure you should be spreading the word about the breakfast. Even if the talk is no good, you can be sure that people should come. So what I'm going to do is to talk about the transformation of India's health system since 1980. And this, as Michael says, I have been working in and around aspects of health policy in India, also earlier on in Pakistan, and some aspects of comparison with Nepal and Sri Lanka over the last, well, since 1970, really. And the purpose of this talk really is not to give you a detailed account of any part of that research, but to try and provide an overview, which is a rather stupid thing to try and do given the range and variety of changes within the Indian health system over this 30-year period. So I shall be very selective. I shall go relatively quickly, and I hope there'll be enough time at the end for people who've got interest in any particular area to come back at me and either challenge my interpretations or ask for clarification and so on. So transformation is an easy word, but I shall try and talk about how things have changed and how far things have stayed the same without descending to the banalities of, well, some things change and some things don't. The systems that I'm talking about, it's rather than, much of the literature talks about the Indian health system, and I suggest really that that's a bit simple. There are varieties of systems, but I think I'm going to argue at the end that nonetheless they hang together in a coherent or perhaps somewhat incoherent way. But those are just three of the kinds of different elements within the systems that I shall at least refer to. So public-private and mixed public-private partnerships of various kinds, cosmopolitan. Within India, it's known as allopathic. It's the medicine that is practiced in this building, I would suggest. Varieties of indigenous medicine and varieties of combinations of medicines which are used by patients and practitioners in eclectic and very often innovative ways. And aspects of the Indian provision, which is both local and global. And indeed, one of the things that I talked about in my book, The Politics of Health in India, which came out in 1988 or something, was to try and look at India in a global health economy. So part of the story is how India's position within that global health economy has changed over the 30-year period that I'm trying to cover. So just very briefly, the situation around the end of the 1970s. Of course, none of these dates mean a great deal, and various things occur at different points before and after 1980, so I'm not intending to suggest that 1980 is particularly significant in and of itself. But that's the kind of picture that most people would have drawn if they'd been asked to describe the situation in India. Mostly communicable diseases, diseases of poverty, considerable burdens of infant mortality, child mortality, a lot of discussion of the role of weanling diarrhea and the impact of that on mortality in the second and third years of life, but also very high levels of maternal mortality. I'm not really going to be talking a great deal about that. And vast amounts of public ill health being generated outside the ken of the health system. So very limited reach of the public health services, particularly in the countryside and in urban slums. At the time, however, the public sector was definitely dominant. And one of the things that my book was criticized for was focusing too exclusively on the public sector and not noticing the extent to which the private sector was beginning to grow and become more significant. Now, the public sector, and indeed most of the book that a lot of the book that I wrote when it referred to the post-independence period, was supported in a variety of ways by the central government, the state government, by international donors, and developed a model of primary health care, which is not that dissimilar in some respects, based upon the 1920 Lord Dawson of Penn report that started the ideas of primary health centres in the UK. But at the time, that public sector was certainly incapable of delivering most of the services that it offered without charging patients and their kin for drugs, for various kinds of facilities, for tests and so on. So there was a public sector which claimed to be delivering a welfare state, but was actually incapable of doing so. So there was a mismatch between what was on the books and what most people actually experienced when they went either to the lowest level facilities or to the large medical college hospitals and so on in the big cities. Rural primary health care, certainly at the time, again, had a lot of promise. It was supposedly where a number of vertical programs came together and delivered somewhat integrated care for the rural population. Never had the same kind of organized structure for the urban population. But in the period up until 1977, as some of you will know, there was considerable pressure within the government for what was practically compulsory sterilization programs, particularly in the north of India. And even after 1977, when Mrs. Gandhi was thrown out at the elections, there was still, in a variety of ways, a great pressure on reproductive health, which was interpreted really as getting these women sterilized. So regular pressure on the health services to deliver contraceptive services, which made them very unpopular in many parts of the country, undermined all sorts of other aspects of reproductive health care. Urban primary health care services were completely disorganized, very often overlapping provisions by urban municipalities, some things by the state government, and some services from the central government, but no coherent planning or structure in most towns. Don't hold me to the detail if you know a particular town where it was different, but that's a generalization. And Indian pharmaceutical companies were beginning to take advantage by the end of the 1970s of a change in the law. I think the law actually was 1970, but it was implemented from 1971 onwards, which provided innovator companies only protection for the process by which they made drugs. So the drug itself was not protected by patent, and if you could find a different way of making it in India, then the government was perfectly okay with giving you a license to manufacture it. Not at all popular, as you might imagine, globally, but not seen as significant. These companies were essentially supplying the Indian market with lower cost drugs and not posing a threat or contributing to global trade. Donor agencies, I've already suggested, played a considerable part in my book. Certainly, I think there's a chapter, or there's certainly a section of a chapter, which talks about how donor agencies influenced government health programs, and I got into trouble with a local professor of public health by arguing that donor agencies were not, in fact, very influential, that most of the things that I'm talking about come out of indigenous processes within India. There was a lot of discussion at the time about the potential for participatory approaches in primary health care, lots of NGOs doing participatory projects, and government was under considerable pressure to introduce community health volunteers, and they were spread across the country, rolled out in programs, particularly after 1979. And finally, there was a considerable mismatch between the training of doctors, which took most of the funds for medical education rather than nurses or other kinds of paramedical practitioners, but doctors very unwilling to work in rural areas, very unwilling to work in primary care, in urban slums, very much drawn towards tertiary care in the cities or to go abroad to work. So untrained or semi-trained practitioners were the dominant providers of medical services in the countryside and in large parts of the towns. So I hope you can keep all that in your head for the next 20 minutes or so until I come back to a similarly brief overview summary of what I think the situation is like at the moment. Before I go any further, just to repeat something that I said right at the beginning, these generalizations don't apply to the same extent across the country. So there's considerable differences between the nature of provision, the quality of provision in Kerala, say, in the southwest of the country, and in Bihar, in the north central of the country, or in Uttar Pradesh, which is the biggest state, now has 200 million people, in the center north of India, where what I've described is most obvious, whereas in Kerala or in Tamil Nadu in the south, you'd argue that some of these generalizations are a bit unfair. So keep that in mind, please. Don't get back at me for maligning the South. So I'm going to give you, rather than try and cover the complete range of things that I think have changed or how they've changed, these are three somewhat randomly selected examples, which I know something about, partly because these are topics that we've done some research on over the last 10 years, but none of which I'm particularly an expert in. So TB control, which is a kind of example of one of the areas where India's health services have not succeeded to the extent that they might be expected to have done. And I think that shows us some rather interesting features of things that haven't changed or haven't changed as much as they might be expected to. Medical tourism, which is a term which I'm increasingly unhappy with, and indeed so is the government of India, but they don't know how to replace it. Medical mobility for medical treatment is perhaps a less problematic way of describing it. And the role of the Indian generics pharmaceuticals companies and their activities over the last 30 years. So TB control. One of the nice things about this slide is that, if I can get this, if I press the right thing, this kind of clinic is exactly the kind of clinic you'll see over large parts of North India. One doctor clinics. This man says he is a doctor, but I can't read what qualifications he claims to have. So set up in a small building in the midst of a shopping area, or indeed just almost anywhere that somebody's been able to get hold of some land, and offering treatment to anybody who comes in through the door, usually on a 1 or 2 day, 3 day basis. So that's the kind of the overwhelming pattern of patients consulting practitioners in large parts of India. Not quite random visits, that people will have their preferences. They will go regularly for small problems to a practitioner of this kind, who will diagnose and sell a medicine at the same time. I mean, usually sell 7 or 8 medicines at the same time in one or two drugs at a time. Now, as one can imagine, that's not a model that goes very well with TB control. TB control requires clear diagnosis and then 6 or 7 months minimum of a series of staged treatments, which the patient has to take on a daily or bi-daily basis. And so until about 1992, when the DOTS program was introduced in India, there was considerable uncertainty about the extent of what they call compliance, what we might call some other things as well, and uncertainty about how far TB was really being controlled. So they introduced a revised national tuberculosis control program in 1992, in order to improve the extent to which patients were seen to be taking their medicines and were monitored and surveyed over the full period of the treatment to ensure that they recovered completely in order to prevent the growth of drug-resistant TB. Medicines under DOTS were free. DOTS is directly observed treatment short course, so it's the direct observation that's the key to this. But of course that means that the services have to be taken to the doorstep of the patient. Unless the patient can be persuaded to come in every day, or whoever's delivering the service can actually go and find them, then they don't get directly observed. They don't come in. The treatment gets disrupted, and there's the danger of relapse. So prepackaged combinations observed, and originally through government servants of one kind, but increasingly acknowledging that they had to take account of a private sector that was out of their control, which was actually delivering still a considerable part of the TB drugs in circulation in the country. So these are free. This is a national program. This is a national program which is supposedly rolled out across the whole country. But in fact, most people with TB are buying their drugs. At least 70% by value of TB drugs sold in India are sold through the private sector, not channeled through the public sector and delivered free to patients. So this particular scheme exemplifies one of the major problems facing the Indian health services, of a large, relatively sometimes well-funded government sector attempting to deliver public health services in a situation where most people are actually seeing on a regular basis practitioners who are completely outside the control of the government system. Indeed, somebody like this probably is breaking the law, though the law doesn't prevent unqualified practice. It doesn't protect the practitioner from various kinds of problems. And there are certain drugs which unqualified practitioners are not supposed to prescribe. But actually they do prescribe them, and of course that means that the government is very unwilling to recognize these people as potential partners in the delivery, in this case, of TB services. So you get programs saying we must involve the private sector, and the private sector turns out to be just those who've been fully trained with an MBBS degree. So it still leaves out of account these people who are semi-legal or illegal practitioners, but are actually delivering a large part of the care. So that still remains the case, essentially. These problems of how to ensure maximum coverage of delivery of these drugs to people, particularly migrants who don't fit into the static model that the TB control program involves, or slum dwellers and other very poor people who are, of course, the most likely to get TB. So what's happened over this 30-year period, certainly since 1992, it's made a considerable difference. There's certainly no doubt of that. But it's not controlled TB. India remains the worst performer, in one quote at any rate, among developing nations, with 17% of the global population, that's the Indian 1.2 billion people, carrying over a quarter of the global burden. Now this is the test that I brought you into the room for. Would anybody like to read the sign? No? Well, in that case, I can persuade you and nobody will know the difference. It says DOTS, Pura course, Paka Ilaj. The full course, a proper treatment. But the full course is not what is actually a feature of the way in which the system has developed over the past 20 years, since 1992. So you still have a very high burden of TB, and because of the failure of coverage of people as they go through the supposed standard treatment, then you've got very considerable problems of drug resistance, multi-drug resistance. totally drug resistant is the way it was described in the press. I think the specialists would say that that's a nonsense. But resistance to a considerable range of the current drugs that are used to treat TB. And in a situation where the system is virtually incapable of identifying people with multi-drug resistant TB and hasn't got the funds to treat them when it does so. So there are, as it were, out in the population, people with multi-drug resistant TB in considerable numbers, but we don't know how many, and being treated, but we don't know how, by practitioners, but we don't know who. So it's not exactly a positive situation at the moment. Just to make things worse, the public sector is showing the signs of really creaking in terms of actually delivering the standard packages of treatment for TB, rifampicin and isoniazid. I never know how to pronounce that. So this is a very unusual. You don't usually get health, except in HIV patients, patients protesting about lack of drugs and inability to get hold of them. But earlier this year, it became obvious that the government had failed to order the drugs it needed to keep the program going. So, as this activist said, despite being warned about the problem, the central government, which does the procurement, had failed to buy these drugs in. So patients are now being put back into the market. And Lupin is one of the world's largest producers of the major anti-TB drugs, rifampicin and so on, is an Indian-based company. So in principle, there should be no difficulty, but in practice, getting the drugs into the clinics has turned out to be something which has gone completely wrong this year. Okay, so that's one example. The second example is patient mobility, or medical tourism, as most people know it. In the 1970s, this wasn't something that I said in my overview, but it was, well, I've lived in India in 1975-76, in 1982-83, and reading the newspapers, there were regular semi-scandals because some powerful person in the public sphere was going abroad for treatment, for a heart bypass, for cancer treatment, whatever it might be. And the nationalist press would get up most of the press in India is nationalist in this sense, would get up very upset about this and raise a fuss about why it was that they were getting access to healthcare services, medical services that the average person in the street could not. And why was it that politicians, when it came to their own care, would go abroad to get it? What I didn't identify as a possibility when I was writing in the early 1980s was the extent to which hospitals in some parts of the country, particularly in the West, in Bombay, as it then was, or in Trivandrum, in Kerala, or in Chennai, Madras, were orienting towards the possibility of attracting patients from other parts of the world. And to begin with, these were mostly from the Gulf or from Southeast Asia, from Malaysia and Indonesia. But increasingly, over the course of the last 30 years, large corporate organizations have moved into the provision of medical services. And this is something which was really unknown in India in the 1980s. So around 1980, there were private clinics, but these were relatively small, locally based, serving a suburb in Delhi or in other cities, with a reach out into the countryside roundabout, but not able to offer large-scale facilities of this kind. All of those were in the public sector or were in various not-for-profit organizations, either missionary and originally, as with the Christian Medical College in Lahore, in Ludhiana, or in Vellore, or in various other kinds of not-for-profit organizations like the Sir Ganga Ram Hospital in Delhi. So in the 1980s and the 1990s, big money comes in and establishes big hospitals and begins to attract not just wealthy patients from commercial hubs like Bombay, but also from abroad. And since 2000, India has been marketed as a global medical destination. And this, I thought, was a lovely example of some of the hype that goes into the commercial marketing of these facilities. So, sorry, it's a bit small, but Medanta, the Medicity, is based just south of Delhi. In fact, it's nearer to Delhi airport than Delhi. It's easier to get there. And there are various adverts, not just in Delhi airport, but certainly in Bombay airport, Mumbai airport, offering access to this kind of facility for people coming from abroad. So just wanted to draw attention to highest standards healthcare delivery across the world, but at an affordable cost. The multi-super, when I was in India first, you had specialties, and then you had super specialties. This is the first time I've seen multi-super specialties, who are leaders from all over the world. The number of times global or world, and so on, we get the part of the world. It's a claim that is made, I think, entirely these people haven't got the tongue in the side of their mouth when they're saying this. This isn't something that they think is really a bit ridiculous, but they'll try it on. This is what they believe. And Naresh Trehan, I think, is the director of this facility just outside Delhi. And he's serious about this. This is India's moment in medical history. So this is the kind of thing that you get if you go into the hospital. That I couldn't download. I suppose if I was clever at these things, I could have downloaded the photo sequence that they have on their website. But I do love this, this 675 years of experience. I'm not sure if that's just these 15 people, because I think if so, they would look rather older than they do. But and I can't read these to the extent to which, what their qualifications are and where they're from. But what we describe, and then as you can see in this one, the OPD with its lovely art is for what the Indian, North Indian middle classes, but also it's designed for overseas patients. One of the things that we'd like to do research on but failed to get funding for was to look at this kind of facility and to see how it developed, where its funding comes from, how far it's actually delivering on providing services of this kind to a global market, who these doctors are, and to what extent this reflects a dramatic change in the position of India within a global medical health economy. So the proposal that we didn't get funded for was called Reversing Medical Flows, was looking at the ways in which patients were no longer leaving India to get treatment abroad, but others were coming in, and doctors were no longer leaving India in order to get training and decent jobs, but were returning to India to deliver these services in India. And the third leg of this proposal was to look at clinical trials and to see how knowledge might be being created within India for export elsewhere rather than being created elsewhere for import into India. As I say, we didn't get funding, but it's still an issue that we're very interested in. So what this example does is, I think, more clearly than anything else, highlight the disjunction between the facilities, the development of facilities and arrangements for the mass of the population, which is based on trivial sums of money. 1.2% of the gross domestic product is spent on health by the government. I think that's a public health expenditure, which is one of the lowest in the world. So on the one hand, you have the starvation, if you like, of medical facilities for the common person who's dependent on, certainly anybody who's dependent on government facilities. And on the other hand, you have services which are so attractive enough to bring patients from almost anywhere. Significant rise in patients from the US, UK, and Europe in the recent past, and for a variety of reasons, particularly rapid treatment at lower costs. The cost comparisons are fairly dramatic. This is the kind, again, this is advertising, of course, this is marketing behavior, but these figures are probably not far out. I don't know the date, I'm afraid, but that's the American Medical Association's estimates. So clearly, if you are in the US, or even, if you're in the US or maybe some other parts of the world, and you're looking around for your best buy, then you might well decide to come to India to have your knee replacement or your spinal fusion done. But if you're in the UK and you feel that your life is worth more than waiting 6 months for your knee replacement, then these are figures that are within many people's bounds. So my third example is the transformation in the position of the pharmaceutical companies within India, the rise of Indian generic producers. At the end of the 1970s, this was a picture which I think is it hadn't changed a vast amount in the previous 10 years. 39% of sales by foreign-owned companies, 51% by Indian private companies. That was growth over the previous 10 years. And 10% by Indian public sector companies. And this was essentially supplying the Indian market. There were some exports, but not a great deal. And this does represent a dramatic transformation. So one of the things that I learned as a first or second year economist back in the 1960s was the argument about infant industries. If you have an infant industry, you need to protect it until it can compete in the global market. Now that's an argument that's been used to justify tariff protection, export controls, import controls, and so on, in many places over many periods. This is one of the best examples of its success. So from 1971 till 1995, the government of India's position was that it would uphold this much weaker patent protection. Companies could reverse engineer the production of drugs as long as they'd used a new process that would allow them to deliver that drug, to make that drug for the Indian market. And they became very good at it. They became exceptionally good at it, such that in the negotiations in 1995 around the creation of the World Trade Organization, when you have the trade-related intellectual property provisions being developed, the Indian government switches from a position of hostility to including intellectual property within the World Trade Organization in order to continue the infant industry protection. It switches to welcoming the inclusion of intellectual property as a way in which its own pharmaceutical companies will be able to compete fully on a global scale and become innovator companies themselves. So from a situation in which they were very much technically very limited, they became a situation where they thought they could take on big pharma globally and make a go of it. So the companies changed their position, the government changed its position, and in 2005, the Indian government's new Patent Act came in, which in many respects, but not entirely, allies the Indian patent system with that in the rest of the world. So this is apparently a considerable transformation, and one that's of benefit, one might think, to the rest of the world. So this is the kind of headline that one could see in 2001. Cipla is an amazing company. It's amazing partly because it's the managing director, the guy who runs it, who's the son of the founder, a man called Y.K. Hamid, is very, very talkative, full of very good talk about what the company is doing and why it is working on this kind of model of trying to involve the best interests of the patients, the consumers, in its business model, certainly trying to deliver to the bottom of the pyramid, not serving just the wealthy, and using very clever public relations to get across the idea that essentially they're Robin Hoods, that they are taking on the big pharmaceutical companies who are otherwise completely interested solely in profits by delivering the drugs at a great deal lower prices and challenging a series of practices globally which work to the interests of the companies and not to the interests of the consumers. So this is the classic from 10,000 or 15,000 per US dollars per patient per year that was being charged by companies for a combination of antiretroviral drugs in 2000 to offering them for $350 per patient per year to MSF. And a storm arises, huge numbers of patient groups get involved, big pharmaceutical companies are shamed into reducing their prices. And this is an image that has been retained. So particularly MSF, Médecins Sans Frontières, will say that Indian companies are drug suppliers to the developing world, they must be protected, they're basically good guys, as opposed to Roche and Pfizer and so on, who are basically bad guys. Unfortunately, there's two sides to this story. So the other side of the story is that it's not at all clear whether Indian companies can be trusted to deliver on their promises. So Cipla itself is actually in the dock for overcharging. It's got huge bills against it in Indian courts that it hasn't paid for charging more than it should do according to Indian government rules for drugs within India. But Ranbaxy is the case that has, again, hit the headlines this year particularly. I take 1 minute to deviate slightly. We wrote a paper, a group of us from one of the projects that Michael mentioned, on trust in pharmaceuticals, which came out in Globalization and Health a couple of years ago, in which we said the FDA, the US FDA, was behaving in ways that seemed to be designed to increase distrust, and as far as we can see, on the basis of very little evidence. And the example we used was Ranbaxy. And 3 years later, we discovered why the US FDA was going so hammer and tongs to suggest that they couldn't be trusted, because Ranbaxy admitted all of these things that they'd been doing. And Ranbaxy is not a small company. It's the largest was the largest Indian domestic producer before it was taken over by Daiichi Sankyo. And they're now rather upset about the effect of these behaviors on the value of their investment. Okay, so to conclude, these are three, as I said, not quite random examples. They certainly can't capture the full range of ways in which the Indian health system has changed over the past 30 years. This is an overall summary, which I hope is a slightly more defensible picture. So certainly in the last 30 years, the pattern of disease morbidity and mortality has shifted. Infant mortality rates have come down. Maternal mortality rates, even in the last 10 years, have begun to drop to levels that are more reliable. But they're still quite a long way. India is still quite a long way from meeting the Millennium Development Goals for health-related topics. The public sector has been increasingly replaced by the private sector in many respects. But what is interesting about the situation, I think, over the last 10 years in particular, is that the government of India and some of the state governments have attempted to maintain a position for a public health service, a kind of welfare state, by pouring massive sums into what was originally a national rural health mission. There was going to be a national urban health mission that never got off the ground, and now there's a national health mission which is supposed to cover both. So this can be seen either as a kind of rearguard attempt to maintain a belief in a public health service, or as cynical populist attempts to buy off the population in time for the next election. And certainly there's evidence on both of those. There's Food for Work and there's various other kinds of food programs which, again, are massively funded but seem and would have positive public health effects, but which seem to be somewhat cynically delivered. Out-of-pocket medical expenditures remain high. Universal health insurance schemes have been introduced in small areas in parts of the country. I think it's still not clear whether or not they're ever going to be possible to roll that out on a national basis until more of the Indian population is in employment rather than in jobs which don't allow for regular contributions. Much more use of public-private partnerships of various kinds, handing over various primary health facilities to NGOs to run, for example. I think that's not clear whether or not these are working better than the original services. Rural primary health care is very different regionally, so in some parts of the country it seems to be working quite well. In the places where it's really needed, in the poorer North Indian and Eastern Indian states, probably still as inefficient and unavailable as it always was. And urban healthcare services are still disorganized, but are now challenged by the rise of these expensive high-tech facilities which appear to offer the best in medical care and are used by many practitioners to demand additional tests, additional inpatient treatments, and so on. One of the, I think, if not the largest cause of households dropping into poverty is the illness of one of its members. Indian pharmaceutical companies are back in the global intellectual property regulatory regime, and that's a big change. And it's not, I don't think it's going to go away despite the efforts of big pharma to limit their activities. Donor agencies are increasingly unimportant, though there are still ways in which their presence and absence makes a difference. Popular participation in primary health care is almost, I really don't see any discussion of this. I don't think anybody's, there are things called health committees in many villages. Nobody knows what they do. Many of the members don't even know that they're members of the committee. It's just an inability to generate that. And we still have, we still have major problems in finding doctors willing to work in rural areas. What's changed is graduates in Ayush. Ayush is Ayurvedic, yoga, Unani, Siddha, or homeopathic. In other words, it's a term to include as many different forms of indigenous medicine as possible, each of which has training programs, each of which has now a place recruitment within the public services. And very often it's people with these qualifications who are manning health posts in the countryside. Or they've set up clinics and so on. So the countryside, which has still got 60 or 70% of the population in most of the country, is still being served to a large measure by this kind of practitioner. So my final slide, it's always good to end with a question, but it's usually better if you end with a question that you yourself can answer, and I'm not sure that I can answer this one. But this is my overview. So increasing inequality, that's clearly the case. At the top of the scale, ready accessibility to services that you or I would expect to find in a hospital like this, compared to district hospitals serving maybe a population of 500,000 or 3 million in some cases that are poorly stocked with drugs, poor with facilities that very often don't work because they don't have electricity on a regular basis or they don't have a good water supply, and supposedly providing a range of services. Populist governments offering a welfare state but failing to deliver it, and a real uncertainty in my mind as to what kind of future there is for the public sector in a situation of this kind. The question that I'm asking really at the end is this really a situation in which there are two different health systems developing, one for the rich and one for the poor, and they're just traveling away in different directions? Or is it more useful to see this as a system that is symbiotic, that these are related? And I leave you with that question. Thank you.